Good morning and welcome to Managing Diabetes in a Busy Life. Today's webinar comes to you from the Wisconsin Council of the Blind and Visually Impaired. Our mission is to promote the dignity and empowerment of the people of Wisconsin who are blind or visually impaired through legislative advocacy, vision services, and education. We were founded in 1952 and are governed by people who are blind or visually impaired. The sponsor of today's webinar is IBVI, Industries for the Blind and Visually Impaired. Today's speaker is Dr. Dawn Davis. She comes to us through the University of Wisconsin's Badger Talks program. Dawn is an associate professor in the Department of Medicine, Division of Endocrinology, Diabetes, and Metabolism. She grew up in Fort Atkinson, Wisconsin. She received her BS in biochemistry from UW-Madison. She then received her MD and PhD degrees from the University of Chicago. She currently practices endocrinology at the UW and VA, runs a federally funded research program focused on diabetes and obesity, and teaches in the graduate and medical schools.
Thank you, Jean. I'm really happy to be here today. Thank you so much for the invitation. And I'm looking forward to talking with you all this morning a bit about diabetes, and we'll touch on a lot of topics. I put together some slides for everyone, but I also would love this to be as interactive as possible. So please don't hesitate to interrupt me, ask a question, put something in the chat, or if we get to the end of the slides, which I'm hoping we'll do in about 30 minutes or so, we'll have plenty of time for questions at the end, and I'd love to hear a bit more about your particular questions. So a little hard to do on Zoom, I guess, but maybe I could just have a couple of you throw in the chat box a bit about your own personal experience with diabetes. I just would like to get a sense of how many people in the audience have diabetes or live with someone with diabetes or know a lot about diabetes already. So if you want to just throw a bit of that in the chat, that will help me also to gauge the presentation as we go forward. As we already talked about, I have a number of roles at UW-Madison. I both am a physician who takes care of patients with diabetes and other endocrine diseases in my clinic. But I am also involved in research where we're studying new therapies to try to treat and prevent diabetes. And we also do a lot of teaching, both formal teaching at the medical school and the graduate school, but I try to do as much of this type of outreach as I can to try to help educate the public about diabetes as well. Let me just start with some definitions, and I'll keep watching in the chat box as we go, and don't feel like you have to write in there if you don't want to, but that's just a way for me to have an understanding of the audience a bit. We're going to start with some very basic definitions just so that we're all on the same page. So what is diabetes, first of all? So diabetes is very simply a disease where you have high amounts of blood glucose, or often commonly called blood sugar in the blood. Diabetes essentially is when there's imbalance between how your body clears that glucose or sugar out of the bloodstream and moves it into the tissues of your body where it's needed for energy. So just to kind of talk through how that all happens, every time we eat, those calories and nutrients, including sugars and glucose, come into our body and get absorbed into the bloodstream. And then they need to move from the bloodstream into the other tissues of your body where your body uses these fuels as energy. So sugar is an energy source. Glucose is an energy source that your body needs. Your brain needs glucose to function. Your muscles need glucose to function. Under normal conditions, as soon as you eat, your body takes that sugar that you just ate and moves it into the appropriate part of the body to either store it for later or use it for energy now. And what happens in diabetes is essentially that doesn't work properly. And what happens then is that the blood glucose levels end up higher than they should be, and that can lead to long-term problems down the road, as well as sometimes short-term problems. Just a brief definitions on diabetes. So there are two main types of diabetes that we talk about: type 1 diabetes, which is on the left-hand side of this slide, and type 2 diabetes on the right-hand side of the slide. Type 1 diabetes is an autoimmune disease. That means that it happens because the body starts basically attacking itself and destroying its own tissues due to a process where your immune system starts attacking your own cells. Type 1 diabetes is autoimmune disease, and it used to be called juvenile diabetes because it happened more commonly in children. However, it does also occur in adults, so it is not unique to children only. And then obviously people who get type 1 diabetes as children eventually grow up to be adults with type 1 diabetes. Excuse me. In type 1 diabetes, what happens is that autoimmune process ultimately destroys all of the cells within your body that produce insulin. And therefore, these patients have an absolute requirement for insulin therapy. They cannot make any insulin on their own, and they have to take insulin every day to manage their blood glucose levels. On the other side, on the right-hand side of the slide, is a brief discussion of type 2 diabetes. So type 2 diabetes is by far the most common form of diabetes. It represents about 95% of the cases of diabetes in the world are type 2 diabetes. And it typically occurs in adults, although nowadays we do sometimes make the diagnosis even in children or teenagers. Type 2 diabetes is the form of diabetes that is associated with obesity or being overweight. Now, not everyone who has type 2 diabetes is overweight. There are other things that can contribute to type 2 diabetes, but it is commonly seen in patients who are overweight or obese. In the case of type 2 diabetes, instead of having an absolute destruction of those insulin-producing cells, one of the main problems is what we call a resistance to insulin, which means that although your body might be making insulin, it doesn't respond to insulin as well, and therefore it doesn't clear that blood glucose or blood sugar out of your system as well as it should. So patients with type 2 diabetes can be treated with oral medications that help them lower their blood sugars, or with insulin. And I see in the chat box, at least one person mentioned that they have type 2 diabetes and take insulin, which is very common. A lot of our type 2 patients also require insulin therapy. I know this is a little bit hard to see, but I wanted to just include another visual that might help some of you to kind of talk through what we just mentioned. So this is, again, kind of a picture of what we just talked through in words. I'll walk you through it again. On the top here, the top box says healthy. Okay, so this is what should happen under normal conditions. And what we have a picture of here is the pancreas, which is the organ that's within your abdomen that helps your body process and digest food and also secretes insulin. So these tiny little blue triangles here represent insulin, which is being released from your pancreas every time you eat. And insulin then goes, as I mentioned earlier, to all the cells in your body, and it sort of acts like the key that unlocks the ability of that cell to then allow glucose or sugar to enter into the cell. So when the insulin comes to the cell, it opens this little pink channel, which allows glucose, which are these little pink circles, to enter into the cell and therefore clear it out of the bloodstream. What happens in type 1 diabetes, which is the panel in the middle, is that you do not make enough insulin. You see there's almost no little blue triangles here, and therefore you accumulate glucose, these pink circles, in the blood outside of the cell, and you can't get glucose into the cell because you don't have that key to kind of open up the lock. And then the bottom panel here is type 2 diabetes, again, the most common form. In type 2 diabetes, you may still produce insulin, but again, the key doesn't really work in as well as it should, so it's not fully opening the lock and not allowing that glucose to come into the cell. Diabetes is very common and highly prevalent in this country and across the world. Right now, 27 million people have diabetes in the United States, which is about a little over 8% of the population. That's about the same in Wisconsin. Our current rate in Wisconsin is right around 8.5% of adults in Wisconsin have diabetes. And unfortunately, we estimate that there's another 7 million people who have undiagnosed diabetes, which means that they don't even realize that they have a problem yet, and eventually will probably come to medical attention. And the reason this is a big concern is that diabetes is a silent disease for the most part. Having a high blood sugar doesn't necessarily cause any symptoms, so you may feel completely normal when your blood sugar is high. And because of that, people are often undiagnosed for many years before they they find out that they actually have diabetes. So part of the goal of trying to prevent diabetes and its complications is to help people get diagnosed earlier. And that means that they need to be seeing a medical provider and getting screening and blood tests and things to look for diabetes at least regular intervals. We recommend for certain patients every year they should be screened for diabetes depending on their age and other risk factors. And then briefly to mention age is an important risk factor. So type 2 diabetes is a disease associated with obesity and overweight, but it's also associated with aging. And we know that as people age, their risk of developing diabetes goes up significantly. And if we look specifically at patients over the age of 65, almost a third of those patients have diabetes. So diabetes is only 8% in the general population, but as we get into the older population, it affects 25 to 35% of the patients. So it's very common as people get older. And unfortunately, diabetes is incredibly expensive. The total cost of diagnosed diabetes in the United States in 2017 was $327 billion with a B dollars. So that includes the cost of medications, hospitalizations, medical procedures, and also lost work due to illness and other disabilities. Type 2 diabetes also is disproportionately affects people in Black, Hispanic, Native American, and Southeast Asian communities. So these communities are at even higher risk, and in certain Native American communities, the rate of diabetes in adults is approaching 20 to 25%, as opposed to 8% in the general population. So we really try hard to make sure we identify people in those communities at risk and try to work on prevention and treatment and diagnosis in those groups as well. Okay, and I know you can't see the details of this slide, that's okay. The point here is just to start to see the change over time. So what we're looking at here are maps of the United States, starting in 2004 on the far left and moving to 2016 on the far right. And as we get to a darker blue color, that represents a higher rate of diabetes. So the very lightest blue represents 1.5 to 7% diabetes in those counties or states. And as we get to the darkest blue color, like the navy blue, that represents between 12 and 33% diabetes in those states. So hopefully what you can appreciate without even seeing the detail here is that between those years of 2004 to 2016, the prevalence of diabetes has gone up pretty dramatically across the country, and that we went from, pale blue in a lot of the country, only 15 years ago in 2004, 16 years ago, and now up to most of the country coming in these darker blue colors. So even in the last few decades, diabetes has really, unfortunately, increased its numbers a lot. And this is leading to a lot more people developing problems, complications, and ultimately, increasing cost of medical care in this country as well. So I wanted to just briefly touch on prediabetes as well. Some of you may have heard of prediabetes. And again, some of the people in the chat box, I think, mentioned like they may have family history of diabetes or other things that might predispose them to diabetes. So prediabetes is a condition that we basically refer to as patients who are kind of in the very early stages of type 2 diabetes. Right now, this affects a lot of people in this country. Prediabetes affects about 88 million adults in this country, which is about 34% or a third. So 1 in every 3 people in the United States has prediabetes. Unfortunately, though, a lot of those people, again, don't know they have prediabetes. So prediabetes is undiagnosed in a very large percentage of the population. And again, that's because they may not be getting routine screening or checkups to look for diabetes, so they don't even realize that they have it. And prediabetes, as I mentioned, it's kind of the precursor or the prelude to diabetes. It happens when there's a mild elevation in blood sugars or blood glucose, and it's not yet at the level that we would diagnose diabetes, but it means that the patient has a very significant risk of progressing to developing type 2 diabetes without any intervention. So patients with prediabetes, more than half of them will develop diabetes within 5 years of their diagnosis of prediabetes. And again, patients who have prediabetes and early type 2 diabetes don't have any symptoms. So it's not something that you necessarily know or notice unless you go in and have a blood test done. The good news, though, is that prediabetes can be reversed or slowed down. In other words, delay the progress toward type 2 diabetes if you are able to achieve even just modest weight loss of about 8% of your body weight. And this is, achieved through changes in diet and exercise and lifestyle. And this is based on a lot of large studies with thousands and thousands of patients who had prediabetes. And it basically showed that even with losing 8% of their body weight, 7 to 8% of their body weight, which again, let's think about what that means. Let's say you weigh 200 pounds, so you need to lose maybe 14 to 16 pounds, which is a lot. I'm not going to say that's easy to do, but then again, I'm also not telling people that they need to lose 50 pounds in order to achieve any results. So even with that about 15-pound weight loss, people can see pretty significant improvement in their prediabetes or early type 2 diabetes. And unfortunately, we know that even before they have a formal diagnosis of diabetes, some patients with prediabetes can begin to develop early complications like eye disease even before they reach the diagnosis of diabetes. So even these patients are at risk of having some complications and need to be followed and monitored closely. Diabetes is, as I mentioned, it's a disease of high sugar in the blood. However, it's actually not the high blood sugar itself that often is what causes severe complications or problems in patients. Patients with diabetes don't typically die from or have symptoms from their high blood sugars. What happens is they develop long-term complications from those high blood sugars that lead to severe symptoms, disability, and ultimately sometimes death. So what we really are trying to prevent by helping patients who have diabetes keep their blood sugars within those goal ranges is we're trying to prevent these complications or long-term consequences of diabetes. And those include things that affect many organs throughout the body. So first of all, patients who have diabetes do have an overall risk of death that is twice that of another adult without diabetes of the same age. So it is a serious disease that does increase your risk of dying, and that's why we need to take it seriously, just like we would any other disease process, and try to do the best we can to treat or reverse it if possible. And relevant to this group, diabetes is the leading cause of blindness in adults, and it leads to about 24,000 cases of blindness per year. It's also the leading cause of kidney failure, which is that second picture there. The first picture is of an eye, the second picture is of a kidney. Diabetes leads to 44,000 cases of end-stage kidney disease every year. These are patients who need to go on dialysis to stay alive and have weekly dialysis sessions in order to help their body clear toxins that are normally cleared by the kidney. And 60 to 70% of patients with diabetes have some nervous system damage. That's the picture, the third picture there is the nerves. Diabetic neuropathy affects a lot of people and sometimes can present with things like numbness, tingling, and painful sensations in the feet. And this is why you often hear about patients with diabetes who have trouble with their feet, and ultimately this can lead to sores and infections in the feet that can lead to amputation, meaning that they have to remove a toe or part of the foot or even the whole foot. So 82,000 amputations per year in this country are due to diabetes. And then finally, probably one of the more important ones as well is the heart and the blood vessels. So we know that heart disease and stroke are the leading cause of death in patients with diabetes. They cause 65% of the deaths in patients with diabetes. And your risk of heart disease and stroke is increased by 2 to 4-fold when you have diabetes. So again, as I mentioned, a big part of what we're doing as medical care providers and physicians trying to treat patients with diabetes is reduce their risk of all of these complications, including heart attack and stroke. Occasionally, patients who have diabetes, both type 1 and even type 2, can become pregnant, and this can lead to complications during pregnancy. And then, as I mentioned, although it's much less common, patients with diabetes can have severe consequences, even death from very high or very low blood sugars. Although, again, most patients are really facing these other more common complications that lead to serious problems. So I thought I'd throw in a bit about eye disease, since that is the focus of this group. As I mentioned, one of the major complications from diabetes is eye disease. We often call this retinopathy or diabetic retinopathy. About 11.7% of adults who have diabetes report some vision disability. This picture is trying to illustrate for us what happens in diabetic retinopathy. So on the left, we have a normal eye. If we look here, you can see we're looking in on the far left through the iris and the pupil, and then all the way through to the back of the eye. The back of the eye here is what's called the retina, and the retina contains a lot of blood vessels that help support the retina and feed the cells of the retina. And the retina is actually where you sense light and have the ability to see things and respond to visual stimuli. When patients have diabetic retinopathy, what happens is that these blood vessels in the back of the eye and the retina start to get weak, and they can leak both fluid and blood into the retina. And that fluid and blood causes the retina to break down and to cause hemorrhages or bleeding within the retina that can cause vision loss. You can also see what's called macular edema, which is swelling of the macula, which is the area of the retina right near the optic nerve there. The main issue with diabetic retinopathy is this kind of leakiness of the blood vessels that causes problems over time. In addition to diabetic retinopathy, which is what this picture is showing, patients with diabetes also have increased risk of glaucoma and cataracts as some of the other more common causes of vision disability in these patients. Before I go on to the next slide, I wanted to just give a basic definition of something called the hemoglobin A1C. The hemoglobin A1C is a blood test that your doctor might order to either screen for diabetes or to monitor your overall progress and when you have diabetes. And what it is it's basically a blood test that helps us estimate what your average blood glucose level was over the prior 3 months. And it's reported in a percentage. So the goal for most patients with diabetes is to have their hemoglobin A1C less than 7%, which means that their average blood sugar is less than about 150 milligrams per deciliter. And that's not quite normal, but it means that their risk of developing complications is pretty low if we can get that A1C down below 7%. And again, the only way really to measure A1C is from a blood draw at your lab or doctor's office every 3 months. There are some home testing kits and things like that, but we typically recommend patients have this done with their medical providers. Okay. This slide I wanted to include, although it's a little bit busy, but it helps us to understand a bit more about why we want to get that hemoglobin A1C below 7%. So this is a graph here. If we look across the bottom of the graph, that's the hemoglobin A1C numbers. So it starts at 6, 7, 8, 9, 10, 11, 12. Okay, so that's the numbers moving across the bottom of this graph. And then on the left side is relative risk of developing these complications of diabetes. So what this graph is showing us is that diabetes complications, the risk of having these complications goes up as that hemoglobin A1C goes up, which means the blood glucose levels or blood sugar levels have been higher. So at the top here in purple is eye disease or retinopathy. And what I hope you can appreciate is that this is the most sensitive to blood glucose levels, in that the risk goes up significantly as blood glucose levels go up. And again, the second point here is the A1C of 7%. That's what our goal is to get patients below that. And you can see that that's where the risk starts to go up, really, is around 7% is your A1C. The other lines on this graph are severe kidney disease, which is the second one down in red. Neuropathy, problems with the nerves, is the one in gray, the third one, and then the bottom line here is mild kidney disease in yellow. So they all are higher risk with higher blood glucose, but eye disease is particularly associated with blood sugar levels. So what can we do to prevent diabetes and to prevent the complications of diabetes? So as I already mentioned, we can prevent progression from pre-diabetes to diabetes by reducing body weight by 5 to 7% and getting 25 minutes of physical activity per day. Controlling blood glucose levels can reduce the risk of many of these complications by over 40%. And then another thing that's really important is not just blood sugars, but blood pressure, which may seem unrelated, but high blood pressure and diabetes often go hand in hand. And if we can control blood pressure in patients with diabetes, we can also reduce their complication rates by up to 50%. And we know that early treatment of diabetic retinal disease or eye disease with things like laser treatment can reduce the risk of blindness by 60%, and close care of their feet can reduce amputation rates by 85%. So all patients with diabetes, we want to keep their blood pressure under good control, their blood sugars under good control, get annual eye exams, and also annual close follow-up for foot care. This is the top 5 steps recommended by the American Ophthalmology Association to prevent diabetic eye disease. So as I just mentioned, it's sort of the same things we just talked about. Get a dilated eye exam at least once per year for everyone who has diabetes or prediabetes. Keep your blood sugar at goal, which again is ideally a hemoglobin A1C less than 7%. Maintain healthy blood pressure and cholesterol. Lowering blood pressure can reduce the risk and also slow the progression of diabetic eye disease. Quit smoking, and then finally exercise. So those who exercise were 25% less likely to develop glaucoma and were less likely to get age-related macular degeneration. So exercise can help prevent eye disease, which may seem counterintuitive, but there are data to show that. Managing diabetes today, although we've made a lot of advances and we can do a really good job of managing diabetes, That doesn't mean it's easy. There's still a lot to think about every single day for patients with diabetes. They have to think about the food they're eating, how many carbs they're eating. They may have to take multiple medications a day at multiple times a day. They have to think about exercising and the impact of that exercise on their blood sugars. They need to check their blood sugars, which is the picture down in the bottom right there is a patient checking their blood sugar with a glucometer. And then the bottom middle is a picture of a patient injecting insulin. So patients with diabetes have to be on this every single day, thinking about it every time they eat, every time they exercise, all day long. So it can be stressful and challenging, and patients with diabetes definitely need a lot of support. So just briefly, a few things on prevention and healthy lifestyle. So everyone who has diabetes or pre-diabetes, we recommend that they follow a healthy diet. And the current dietary recommendations, this is from the American Diabetes Association, they recommend kind of a simple approach, which is the healthy plate idea. The healthy plate idea here is where you have half of your plate in green, which is non-starchy vegetables. A quarter of your plate has your protein foods like fish or meat. And then the other quarter of your plate would have carbohydrate foods, starches, potatoes, fruits, other things like that. Following this relatively simple guideline can be an easy way to start thinking about improving diet without having to get too in the weeds on specific types of foods and specific amounts of food every day. I also just threw up a nutrition label here in the top right, which, just so that everyone knows, if you buy prepackaged food, it will contain a nutrition label like this, and right on the nutrition label it does tell you how many carbohydrates are in the food you eat. Carbohydrates aren't necessarily a bad thing, but again, those carbohydrate high foods should be less than a quarter of your, or about a quarter of your plate. It also shows you dietary fiber and sugars, and dietary fiber is a good thing. Those are good carbohydrates. The carbohydrates that are mostly sugars are not typically as good, especially for patients with diabetes. So exercise is an important part of diabetes prevention and diabetes management. We know that exercise is very beneficial for all kinds of reasons. What I always try to tell my patients is that I want everyone to get some exercise, but I think we all have a lot of misconceptions in our head about exercise and what it is and what it means. First of all, exercise is good for everyone. It has all kinds of benefits, but it is not necessarily going to automatically lead to weight loss. And so I think a lot of people think that they need to exercise to lose weight. And I encourage people to try to disconnect those two things and worry more about how their exercise is helping them in other ways of their health, even if their weight doesn't change substantially. These are just a few kind of points and tips about the exercise recommendations. We like to see patients, well, everyone really, not even just with diabetes, but decreasing prolonged sitting. So if you're sitting, and these days we all do a lot of sitting as we watch Zoom meetings and are stuck in our houses. So as much as possible, try to get up with brief standing or just a little bit of walking around the room or around the house every 30 minutes and not be sitting for very long periods of time. 15 minutes of walking after a meal can also help lower that blood sugar after you eat. And our ideal recommendation is 150 minutes of physical activity every week, which breaks down to 30 minutes, 5 days a week. And we recommend that people include both aerobic exercise, which is the exercise that gets your heart rate up and gets you breathing fast. That's going to be walking, biking, treadmill, and also include resistance exercise. And that can be weightlifting, which again, a lot of people say like, oh, I'm not going to be working out and lifting weights. That's for young, bodybuilder types. Weightlifting can include the very small weights, like the 5-pound weights. It can be using your own body weight as the resistance that you're using. You don't even have to have a physical weight. And it can also include things like resistance bands, which are like rubber bands that kind of you pull against them and push against them. There's all kinds of different resistance exercises than just working out in a gym with a weight machine. And all of the benefits of exercise include, as I mentioned, improvement in diabetes control, blood pressure, cholesterol, muscle strength and balance, and bone health are all improved by exercise. Okay, so patients with diabetes also need to check their blood sugar, and I just wanted to talk a bit about what that means. This is a picture on the top right here of a glucose meter. This in particular is one that actually is a talking glucose meter, so this can be very helpful for patients with vision impairment because it speaks out loud what the blood sugar number is as opposed to having to read it. Unfortunately, a lot of these devices are not made with vision impairment in mind, to be honest, and so a lot of times the screens are pretty small and can be very hard to read without for people who have vision impairment. So a talking glucose meter is one way around that. Checking your blood sugar, how often you need to do that depends a lot on your treatment plan. Some patients we don't recommend they check their blood sugar at all. Other patients, we want them to check it 4 or 5 times a day. Typically, we want people to check their blood sugar before meals or about 2 hours after a meal. If you check it too close to the meal, it can look higher than, and it can kind of lead you to be more worried about it than you need to. And then I just threw a picture up here of continuous glucose monitors. This is kind of a new thing that's come out in the last few years, and probably if you ever watch TV, you've seen some advertisements for these. They're very popular right now. This one is called the Freestyle Libre. And what these are is the devices that you essentially attach to your skin, and they continuously look at the blood glucose levels every 5 minutes, and then they send that number to either your smartphone or to another device so that you always can be aware of what your blood sugar is without having to poke your finger and measure it with a glucose meter every time. And so these can be really helpful, particularly for patients on insulin who have to check their blood sugars very often. They also can send alarms, like audible alarms, to patients who have a very high or very low blood sugar. So there's some safety benefits from these as well. Hypoglycemia is a problem that I wanted to just mention as well. So we've been talking so far about diabetes being a disease of high blood sugars, which is true. But in patients who are treated for diabetes, they often can develop hypoglycemia, which is where the blood glucose is too low, less than 70 milligrams per deciliter. And patients who take insulin or even some other medications can develop hypoglycemia. And this would often present with symptoms like shakiness, sweating, rapid heart rate. And what patients need to do when this happens is to basically eat something to bring their blood sugar up as quickly as possible. And low blood sugars can happen from not eating enough food at that time or being too long in between meals, from having too much insulin on board, from exercise or other illnesses can all lead to low blood sugars. And very severe low blood sugars are a medical emergency, and patients sometimes need help from emergency medical personnel to help bring their blood sugar back up. And everyone's diabetes treatment plan should involve prevention of hypoglycemia. So we want to prevent those high blood sugars, but we also want to prevent low blood sugars as well. So we've made a lot of advances in diabetes therapy in the last 50 to 75 years. In the 1950s, patients who were diagnosed with type 1 diabetes, 20% of them died within 20 years. Now remember, a lot of these were children, which means that they were diagnosed as children and they died before they reached their 30s or 40s. Part of them died within 25 years of diagnosis. If we look at type 1 patients born in 1975 to 1980, those patients have done a whole lot better. So only 7% of those patients have died within 25 years of diagnosis. So we've done a huge amount of preventing death in patients with type 1 diabetes because we have a lot of advances that have come out in the 1980s and beyond. Human insulin first became available in 1980. Home blood glucose monitoring, like I just showed you in the last slide, first became available in the 1980s. The first line treatment for type 2 diabetes, which is the drug metformin, was introduced in the United States in 1994. And many new forms of insulin have become available in the 1990s and the 2000s. And just in the past 10 to 15 years, we have 5 new classes of medication for type 2 diabetes that have come to market. So there's lots of continual improvements and advances. In the next slide, I have just a couple of pictures just to kind of show you what life used to be like with diabetes compared to the pictures I showed you just earlier. The first one on the left there is the 1940s. Patients with diabetes had these very complicated home chemistry kits that they would use to measure blood glucose in their urine, and these were not very accurate. They just told them basically if it was very high or not very high. And then even when we first developed those home glucose monitors in the 1980s, that's the picture on the right, they were pretty big and clunky and certainly not something you could put in your purse and carry around with you all day long. So even since, in the last 30, 40 years, we've come a long way in helping make diabetes much more manageable in a busy lifestyle by having a lot of new technology and treatments that help patients manage their diabetes while they're out and about and living their lives. And as I mentioned, our toolbox for type 2 diabetes in particular continues to grow in terms of the number of drugs and classes of drugs that we have available to treat type 2 diabetes. We have over 14 different categories of drugs that we can use now, and several of those are new in the past 5 to 10 years. And we continue to add many new combination therapies and get new evidence and data about a lot of these medications every year. So this is just a few pictures of insulin therapy. I just thought I'd spend a couple minutes talking about insulin. So insulin, as I mentioned, is absolutely required for patients with type 1 diabetes and is commonly used for patients who have type 2 diabetes as well. On the top right picture there is sort of the old school version of insulin, where patients have a vial of insulin and they need to use a syringe to draw up the insulin into the syringe, measure the dose, and then inject the insulin with the syringe. As I mentioned, we've moved forward with a lot of advances that have made insulin therapy more convenient and certainly easier for patients who have visual impairment and other disabilities to use insulin therapy. So the picture on the bottom right is an insulin pen, and the picture on the top left is a person using an insulin pen to inject insulin. The nice thing about insulin pens is that instead of having to draw up insulin with a syringe and see the tiny little numbers on the syringe to know how much insulin you're injecting, patients with insulin pens basically turn a dial at the end of the pen, and it even clicks every time, so they know they can even count the clicks if they can't see the numbers in the dial to figure out how much insulin they're giving. And then it's a much simpler, just push a button to release the insulin after you put the needle under the skin. So it has made it easier for patients with vision impairment and other disabilities to administer insulin every day. And now in the bottom left picture there, we also have insulin pumps, which have been available since the mid-1990s, and the technology there keeps getting better and better as well. Insulin pumps continually infuse insulin throughout the day, and patients need to just kind of push a button in order to deliver extra insulin with an insulin pump. Unfortunately, although we've made a lot of advances, one of the things that has come along with that is that costs have gone up. So insulin is unfortunately very expensive. The average price of insulin in the United States tripled between 2002 and 2013. This graph, which I know is a little bit small on your screen, but if you look at this graph in the bottom right, the blue line here is the price of insulin moving from 2000 to 2013, and you can see this huge increase of about 200% rise in the cost of insulin during those years. That's because we developed a lot of these newer insulins and newer delivery devices, but with that came a much increased cost. And almost all of the newer insulins and other injectables do have some low copay programs, and there are some options, but for a lot of people, insulin is still a huge dent in their budget and ends up costing them a lot of money every month out of pocket. This is my last slide. I guess I didn't have quite as much time for free questions as I had hoped, but we'll still have a few minutes for that. I just wanted to highlight that, one of the things that I'm passionate about, as are lots of people across the country, is that we want to keep doing more and more research to try to prevent diabetes, to treat diabetes more effectively, and to control the complications of diabetes. There's a lot of exciting research going on at UW-Madison. And then there's research funded nationally through the JDRF, which is the association that supports type 1 diabetes research, and then the American Diabetes Association. And these are just some pictures from my lab and others. The one here on the left is with the blue and red. That's a picture of a pancreatic islet. Those are the cells that make insulin. So the little red cells here are the ones making insulin, and the blue cells are making the other hormone, glucagon, that's important in regulating blood glucose. And the picture in the middle there is a chubby little mouse that we use to study obesity and type 2 diabetes in animal models. And then the picture down in the bottom right is just talking about pancreas and islet transplantation, which is one of the exciting new developments that we continue to work on to try to help patients be able to make insulin on their own again after they develop diabetes. All right, that is the end of my slides, and I know we don't have a lot of time left, but I would be very happy to take any questions you guys might have, and I'm happy to stay on a few extra minutes if anyone has further questions too.
Do you actually work with the clinics within your own system to make sure that they're aware of what's going on in diabetes research and how they can address individuals in the clinics? To get in contact with, because I hadn't had an education class in 14 years.
Mm-hmm. Yeah, well, you're right. I mean, this is a big challenge, and I think, part of the challenge is that, as I mentioned in the beginning, diabetes is incredibly prevalent, right? So there's a lot of people with diabetes, and there's certainly not enough of people with highly specialized diabetes care, like endocrinologists, for example. There's not enough of us to take care of everyone with diabetes, and we do have education programs and outreach, and we're trying our best to get that out to the community as a whole, including the medical community. But it is challenging, honestly. You're right. And the other thing that you mentioned, which is really important, is diabetes education. So we have certified diabetes educators who do an amazing job, but unfortunately, again, there's not always enough of them to go around. And so we're trying to get innovative about that, doing group classes and trying to do it in ways where we can touch more people at the same time to have better information out there. So it's a big challenge. I completely agree with you, and it's one of the things that we're all trying our best and working hard to try to improve some of that across the board.
One of the things that I thought was missing in your slides is this. I just recently found out that extreme low birth weight increases your risk of having adult type 2 diabetes by about 40%. And
you're right, it is a risk factor that we don't always appreciate or remember, but it is one that has been kind of pretty clearly documented in the last 10 or 15 years or so. So it may not have been known when your daughter was born, but it certainly has been known now for a while.
Yeah. Since that unfortunate incident at the clinic 2 years ago, I did go to a diabetes re-education at Yahara Clinic. Awesome staff people there. They are really good. And I participated in a class, and I was the only person who wasn't newly diagnosed, and so I had a lot of questions where most people, when they're newly diagnosed, they're like deer in the headlights. They don't even know what to ask. I think that it's possible that maybe you could talk to them about adding somebody, having people who are experienced with diabetes to be able to come sit in on these classes to help people who, if they're not asking questions, to ask questions or something.
It's a good point. I think, that's one of the reasons that we really like the idea of group classes, because it does help to share those experiences and kind of get the conversation going. And I think it also just helps people to be able to kind of see other people with the same challenges and the same, concerns, and realize they're not all alone in this, because it can be kind of isolating sometimes, I think. So yeah, group classes are great. The other, point you made, I think, was that, education is something that we don't recommend only when people are diagnosed. And that's a common misconception and problem, I would say, among patients too. A lot of my patients say, oh, I already went to education, I don't need to go anymore. And the point is, we want them to keep going every year, actually, because there's always more to learn, and always, insight you can get from just having those conversations. So we encourage that, although again, a lot of patients have this misconception that education is only for the very beginning, when you need to learn about diabetes after you're diagnosed. We want people to keep learning as they go.
And I think people don't realize that under Medicare, you can go every year. You can see the nutritionist. You can, and I didn't know that. Mm-hmm. So they were very helpful to me, and I'm in a really good place now, thanks to the reintroduction of the education. That's why education is so important.
Yeah. Well, congratulations. It's thanks to that and a lot of hard work on your part, I'm sure.
And I think that education also has to do with somebody's readiness. Then that's why it's important to also continue going back, because we might hear it at one time, but we're not ready to implement the suggestions.
Absolutely. Yep. And, and to be honest, sometimes it's delivered in a way that helps people to receive it, and other times maybe not so much. And I think sometimes people can have bad experiences with, not necessarily diabetes educators, but just in general with people who are trying to tell them about diabetes, and they get a negative impression. There's a lot of things around guilt and shame and, blaming in diabetes that is a big problem as well. And, again, we're trying to improve how that goes in the language people use, but it's still an issue, and people can get very turned off by those negative interactions, and then they don't want to go back. So hopefully that doesn't happen as much anymore, but it still happens, and it can be hard to turn it around when it does. So
okay. Dawn came to us through a program at UW called Badger Talks. So if anybody has a need for speakers about many different topics, I found out Badger Talks might be a place to go to look for a speaker. And then also just to thank Dawn for sharing her expertise in this webinar. And thanks to all of you for spending an hour with us. My gratitude to our webinar sponsor today, which is Industries for the Blind and Visually Impaired. I'll be sending a short survey to each of you where you can provide us with feedback about today's webinar. And since November is Diabetes Awareness Month, I'll send you the slides so that you'll have those for reference. The webinar will be archived, and that should be done about November 20th. And I'll include in there just some links to some other resources that may be useful for you. If you have any questions, feel free to visit us at wcblind.org or reach out to our staff by calling 800-783-5213. If you'd like to follow the council, please go to our webpage and sign up for our weekly e-newsletters. So enjoy the rest of this rainy November day, and thank you. Bye now.
Hi, thank you all.